This session, I guess, is focusing more on the difficulties that men after cancer will experience. But we do recognise and want to be very inclusive in terms of people who don't self-identify as either male or female and may feel that some of these principles will definitely apply to them as well. And as Catherine said, it's also about looking to support people who may be in a relationship, or indeed those who are not currently in a relationship but maybe thinking about a relationship for the future. So different from December's session, we've included a little bit more specifically in relation to people who might be thinking about dating or thinking about new relationships after cancer as well. Some of the slides will be familiar if people have joined us for the December session. Some of the slides will be familiar, but there will be a significant number of new ones as well. And that's because putting the sexual impact of cancer in context is important for us. And I often use this particular report by Macmillan just to give people a sense of the size or magnitude of the challenge. And I think it's worthwhile looking at the range of medium and long-term problems that people who've been treated for cancer experience. So although today we're focusing on sexual and intimacy issues, clearly if you've got problems affecting other aspects of your life, a bit like Catherine was saying in terms of this integrated model of how people are and also how people experience their illness and treatment, then these will all have a potential impact on our sexual well-being and on our sense of our intimate relationships. So, you know, if you have a mental health difficulty associated with your cancer diagnosis, that won't just affect your emotions, but it will also affect potentially your sexual well-being. So it's important that we think about things in context rather than stripping them out and seeing them as something that's completely separate and removed from how we actually are as a whole person. But if we look at things proportionately within this report, certainly the modelling that Macmillan were doing suggests that about 350,000 people at any time are experiencing sexual difficulties that are directly arising from their treatment for cancer or from the diagnosis impact itself. And one thing to also say is that treatment-late effects often emerge some months after treatment or acute treatment phase is completed, and they can persist in excess of 10 years. And particularly in relation to pelvic radiotherapy side effects, we know that in fact many of the sexual impacts of pelvic radiotherapy don't get better over time. They either stay the same or they may actually deteriorate slightly after time, as time goes by. So it is important that we don't ignore them, imagining that somehow they will get better by themselves. It is important that we try and support people and support each other to actually reach out and get help from whichever source happens to be most accessible and most appropriate to you as an individual. Sometimes it's worthwhile also thinking about what we need for good sex, and when we think of it all in the round, you can then see how cancer and cancer treatment can really dramatically impact on people's experience of sexual well-being. So we need blood vessels, particularly arteries and veins that work. We need nerves that work. We need the right levels of male and or female hormones. We need to feel okay or hopefully good emotionally, and we need to be with someone who is a supportive partner, and that it is not important how long that person you've been with. It's much more about the extent to which they can be supportive of you as an individual and as a partnership, even if that's for a relatively short period of time. So when you think of all of those things that are necessary to experience sex in a good and positive way, you can see how many different ways in which cancer can actually adversely affect that. Another way of looking at it is kind of thinking of it in the context of the human sexual response cycle. So this response cycle was, although they didn't do the diagram, the actual phases of the sexual response cycle were first authored really by Masters and Johnson, who were a very well-known medical sexology couple in the 1960s. they actually worked together initially, and then they married and stayed married for quite some time. But they put together this human sexual response cycle. And so you can see, although I've split it into the phases that they talk about, of course, the phases inevitably, if you have difficulties, for example, caused by your treatment or your illness that adversely affect your sexual desire, that will have a knock-on effect elsewhere in the human response cycle as well. Because if your desire is diminished or absent, then your ability to feel sexual arousal is often impacted as well. Likewise, if your sexual arousal is impacted, it's difficult to then actually manage to achieve orgasm quite commonly. And likewise, if your orgasm is adversely affected, then it may reduce your sexual enjoyment. Not always, but in some instances that can certainly be the case. So what we're going to look at today are predominantly the factors that adversely affect different aspects of the human sexual response cycle, affecting men or people who self-identify as male. But before we do that, from a kind of physical health point of view, as Catherine said, one of the reasons why this whole area is so challenging is that, not just in the UK, but generally across the world, we have real difficulty talking about sex and intimacy with other people. Sometimes we have difficulty talking about it with healthcare professionals, but actually some of us have difficulty talking about it with partners as well. So this was actually a study that was recently published in from America in Psycho-Oncology, a journal for psychology and psychotherapy clinicians. But it was a study, although it was conducted in women with breast cancer, which is a very large number of women that have adverse effects on their sexual well-being. The principles of it, however, I think are not gender specific and can actually be very, very helpful for you irrespective of one's gender. So what they said really was, first of all, it's important to actually identify what your specific concerns are. So maybe make a checklist or find an existing checklist online, but certainly make a checklist of the things that are really bothering you about your sexual well-being. And then try and identify what's your top concern that you want to discuss, because we all know how busy follow-up clinics are. We all know how fast throughput those clinics feel like. Sometimes we may feel we don't really get adequate time with our consultant or with our treatment team. But that's why if we identify all of the problems and then identify the top concern that we want to discuss, we can always give that checklist to our clinicians and say, I'd like to be able to pick up on some of these other elements, perhaps on a separate occasion, or maybe you could advise me who I could speak to about the remaining problems or issues that I'm facing. If we've only got time to discuss one thing, but identify what that top concern is that you really want to address with your clinician on that day. And then try to identify in advance of going into the hospital or wherever you're having your follow-up, maybe you're having it online, try and identify who you think is best placed to help you or the easiest to talk to. And that might not be your consultant. You may feel, well, my consultant's the person who actually deals with the overarching medical management of my condition. Actually, I'd rather speak to the clinical nurse specialist, or I'd rather speak to the therapy radiographer, or I'd rather speak to one of the more junior members of the medical team. But it is about trying to identify who you're going to find it most appropriate to speak to, so that the awkwardness and reticence in the conversation is kept to a minimum. And then practice using this SEA model. And that means try to be as specific as you can be, because we often use vague language around sex and intimacy. So we talk about things, down there. And we don't then really specify what we really mean by that. So we can spend or expend a lot of time going round the houses, not really getting to the point, hoping that the clinician will pick up on that. And the clinician may well be hoping that the patient can also bring it to the fore, because maybe they're having difficulty understanding what it is that's actually being hinted at. So if it's at all possible, try to be as specific as possible. And an example here on the right hand side is, if, for example, someone says, I can't get an erection since my operation, then people are in no doubt whatsoever what the problem is that the person's actually bringing to your attention. And then explain why the concern is important. So saying, and now I'm avoiding sex with my partner because of this, and that's causing maybe some dissent or some tension in our relationship. And then pose the question, is there anything you can suggest I could try for this? And that means that it's very clearly entering into that kind of verbal contract with the clinician that you're in front of. Now, if they can't answer your question at the time, it's perfectly acceptable for them to say, I'm not entirely sure myself, but I will make contact with other people in the hospital or in the setting, or I will make sure that I make links with local services and we'll get back to you. So if they're not able to answer the questions on the day, that's okay, but they do have a duty of care to respond to you and to actually help you network and find the relevant support that you're actually looking for. Sometimes it's helpful, this third point, plan and practice communication, is instead of just going in and thinking, well, I'll just wing it, and maybe not really doing much thinking in advance. While that can be an avoidant kind of behaviour and can make us feel slightly better about it at the time, when we're then in front of a very busy clinic, often it will go out of our minds, or we'll actually feel that pressure and strain even more. So my temptation would be to say to people, why not actually write these things down and rehearse them a little bit at home? Just a bit of practice, maybe with someone that you trust or in front of the mirror, practicing it out loud to hear yourself saying those words so that you can actually adapt the language so that it feels like it's really coming from you, using your personality, using what actually makes you feel comfortable. And then, you know, bring it to your next clinic visit. If you want to write it down and maybe there isn't time, then at least you're able to hand it over to the clinician and say, this was something that we didn't manage to get to today, but I'd really, really welcome some support and some help with this if someone could get back to me, please. And then thinking about our partners, the people that we're in intimate relationships with, whether those are casual relationships or whether those are established relationships or new relationships. Again, talking together about sex can be really, really challenging. And so I guess there are some tips that I would pass on that I think have been shared with me over the years, either through research and publications that I've read, or indeed through actually working with lots of individuals and couples across time. And the first thing I think to say is to try and keep your discussions relatively short. There's a temptation, I think, when something is really important and might be quite emotive, to try and thrash it out to get to the kind of end point of that conversation. But actually, if you speak for very long periods on it, the emotional level within that conversation can sometimes get too high to manage, and that in itself can then be disruptive. So try to keep the discussion short. You can always have several shorter conversations rather than actually trying to spend an hour or 2 hours trying to resolve something that people are actually finding quite challenging to talk through. But again, you know yourselves and you know your partners as to what works best for you. Try to focus on the present and the future, because we can't actually change the past. So it's not always useful or helpful to bring perhaps past events or past resentments or past difficulties into the current situation excessively. We can acknowledge them, but really it's about saying, where are we now and where do we want to be in the future, and how might we get there together in the best way for us both. Try to start with the aspects of expressing your sexual well-being that are less emotive, if there are any. I appreciate that it can be a very emotionally laden subject. Try to check meanings with each other and don't assume that you know what your partner thinks. Even if you've been together a very long time, we're not mind readers, but we may operate on a basis of assumptions, and sometimes those assumptions are not correct. And if we operate on the basis of assumptions without checking them out, it can then lead us to be in a situation where we create a misunderstanding, and that can then make further communication difficult. Try not to interrupt or hijack the conversation while your partner or the person you're talking to is actually talking. Give them the space and time to speak, and then also make sure that you've got time and space to speak as well, while they remain attentive and listening to what you've got to say. And if it helps, try to use humour to keep things light but sparingly, because again, if you feel that someone is laughing at you or laughing at what you're saying, that's likely to be counterproductive and act as a barrier to communication. But sometimes keeping things a little bit light and using a little bit of humour, if that's in keeping with your personalities, that can actually be quite useful to be able to take a sensitive topic like this forward. But key is about being compassionate to yourself and being compassionate to your partner. These aren't easy conversations to have. This may be the first time you've ever had to talk about sex directly with each other. Because quite often we learn about what we need and want sexually by trial and error, and without actually necessarily discussing anything directly at all. So we may find it challenging to find the language to have a conversation on this particular topic. And if it's still too difficult to talk, then would writing a text or a short note to your partner help? Because sometimes that gives us the opportunity to choose our words much more carefully, and that can be really, really helpful and really useful. Try to be solution more than problem focused. It's easy often for us to get into a negative frame where we just think about, well, these are problems and barriers and things that we're finding difficult. But actually, maybe it's about thinking, well, what are we wanting to solve? So let's look at the solutions that might actually help us move forward with the difficulties that we are experiencing. And maybe start in a place which is about affirming what you really love and what you really care about in your relationship. So for example, what do you like about your relationship? What do you find really affirming, reassuring, comfortable in your relationship, exciting and fun in your relationship? And in the elements of being sexual together, what is it that you really value about that side of your relationship? And then each take turn to perhaps gently explore what worries you might have and what are the blocks to the sexual intimacy that you want to find solutions for. And being able to name that, but each of you being able to do that, because the person with the cancer diagnosis will probably have some clarity about what they're finding difficulty, but what they may not always appreciate is that their partner may be trying to accommodate that quietly and silently, but also experiencing real challenge and difficulty in doing so, worrying perhaps about approaching their partner to be intimate because they don't want to put their partner under pressure. And so you end up with this dance of avoidance, which is born out of a really positive intent, which is not wanting to actually cause distress, not wanting to actually cause embarrassment or difficulty for the person that you're fond of, the person that you care about. But inadvertently, you end up perpetuating this avoidance rather than actually being able to address things and take things forward. So it's okay to be tentative, but again, it's about giving each other the space to be able to talk about how you're each experiencing these changes in your life and in your relationship as a direct result of cancer and cancer treatment impact. And if that still feels too much, it's all right just to pick one thing each to talk about and start very small and very manageable. The key thing is naming that it's a challenge or a problem, and then being able to find where you want to start, where you both feel able to start. Taking turns to outline what your concern is and the other person listening carefully to what's being said. What we often do in psychosexual counselling, and this is something that couples can do by themselves as well, is breaking being sexual down into much smaller steps. Being able to agree a beginning where you both feel able to start. And that won't necessarily be about jumping in and having full penetrative sex again, swinging from the rafters and all the kind of, amazing imaginations that we supposedly have in relation to being sexual. Many of us never experience sex in that way, and it's always a very individual experience. So there's no absolute right or wrong way to be sexual. What's really crucial is, what do you like to do with your body? What do you like your partner to do to you and with you and your body? And how has that been affected by your cancer experience, both of you? And how do you therefore want to identify a way of beginning to re-explore what your bodies are capable of, what you both enjoy in terms of sexual touch and arousal, and how you can actually be sexually intimate once more, which may be similar to before your cancer experience or may be radically different depending on what has impacted you. It might involve just sitting on the sofa and actually with your arms round one another, where perhaps you've been sitting separately before. It might be sharing a bath or a shower where you can just gently wash each other and just have that physical skin-to-skin contact. It might be giving each other an intimate massage, not with any particular technique of massage in mind, but just being able to touch and be touched, just to reaffirm the type of touch that you share. Again, it goes back to the points that Catherine made at the very beginning. we like to touch and be touched in a way that gives us pleasure and comfort and relaxation. But actually, when you go through cancer treatment, you're often touched in a very different way. You're touched in a way that alienates you from your body. The touch is often associated with pain or discomfort. The touch is being done clinically. And although it's being done with care and attention from a professional standpoint, it can sometimes alienate us from what our bodies are capable of giving and receiving. And so a lot of it is about reacquainting ourselves with that. It's whatever feels most comfortable and appropriate for each of you. And that may be different from what was a comfortable and appropriate way of touching each other before. So the key thing here again, to protect each other from being distressed, is to agree clear boundaries, where to stop and to stick to them. And what often happens as a barrier to being sexually intimate after cancer is that if we think we can't engage in full intercourse, we actually then avoid everything, because we haven't been able to set boundaries or explain that what we want is a cuddle or a kiss or to be touched, but not to have the expectation that that will necessarily then roll on into full penetrative sex if that's no longer possible, either temporarily or perhaps more persistently. So the key thing is if we're able to break things down into smaller steps and agree boundaries, we can then enjoy some of the sexual and erotic touch and being connected with our partner in that intimate way without the assumption that it has to then follow on and go on to something much more involved, which we may not feel ready for. And if you're still feeling stuck and distressed, and many people are and do feel that way, then think about whether talking to a counsellor or a psychosexual therapist might help you. If you're not in a current relationship and you're thinking about a new relationship after cancer, then again, what are you looking for in that relationship? So having time to actually really consider what it is you're looking for and whether that is similar or different from how you felt about intimate relationships prior to cancer. Is it a hookup? Is it a casual relationship, or is it a more committed relationship? Because there are different sexual challenges with each of them. And again, being aware of what you're looking for and therefore what challenges you might face can be really helpful imagining that in advance. And what are your hopes and fears? And how will you manage these before, during and after your date? And one of the most common fears is fear of rejection. That, you know, we go and put ourselves forward for a date and then find that the person doesn't actually then want to pursue a second date with us. Now that can happen to any of us at any time when we're not in a current relationship and we're looking to enter into the dating scene again. But of course, we have additional anxieties related to our physical health and how our physical body may look different and feel different to us as a result of cancer treatment. So we may feel more vulnerable in terms of being rejected because of those changes in our bodies. And again, it's about being mindful of that and how we can actually manage that situation. But think about also the positive things that you bring to that dating experience. Think about whether you're ready to date and how do you know this? What makes you feel that you are ready? And what do you want from this new relationship experience that you're wanting to introduce yourself to? There is a very useful podcast on dating after cancer by Shine Cancer Support, which is a charity for adults in their 20s, 30s and 40s. So very much targeting those who are a bit younger than I am, but nevertheless, a lot of the principles of how you might tackle dating are relevant to you irrespective of what age you are. One of the things that people really find quite challenging is thinking about, when do I disclose the fact that I've had cancer or I still have cancer and I've had treatment? It's always a personal choice. There's no absolute rights or wrong ways to go about it, and it may depend on where you are in your post-diagnosis, post-treatment period. If you're still in the midst of treatment, it may, of course, be difficult to disguise the fact that perhaps, you know, you look different, you feel different, or your stamina, if you like, your ability from a fatigue point of view may mean that you have to manage your date in a particular way because of the current effects that your cancer treatment's having on you. Whereas if you're much further down the road and you've done a lot of physical and emotional healing after, then again, you may actually feel that you can manage your date differently. some people like to put information about the fact that they've had cancer and been treated for cancer on their dating profile. So they actually state it up front. And that can be useful to filter out unsuitable people, people who maybe would find dating someone who's been treated for cancer too challenging themselves, for whatever reason that might be. And if it's on the dating profile, then it takes the pressure off you to bring up the topic, because you know that the person who's meeting with you already knows that information. While others might choose to wait until they know the person a little and have maybe made a decision that they want to see that person on a second or third occasion. So again, it's a very personal choice. The current situation with COVID and the way in which we approach new relationships, that can sometimes actually help us pace the delivery of new information to someone that we're meeting for the first or subsequent times. So connecting with people online, connecting with people by phone or using messaging services rather than face-to-face can help us pace the information that we want to deliver, and also pace and choose what words we want to use and why. So we've got time to do it rather than being right in front of that person and having to do it in the moment, which can feel a little bit more challenging at times if we're feeling anxious or nervous about it. So we can also practice our choice of words in advance, how you want to say things. You can practice that with friends or someone else that you trust to promote self-comfort. So you can hear yourself saying it and then recognizing whether or not that feels right for you. Treat your dates as practice. They're about building self-confidence and self-compassion and setting yourself small attainable goals in terms of moving things forward in your life. And know in advance how you're going to end the date, for better or for worse. So if you want to get out of that situation because you feel that person isn't right for you, work out in advance how you're going to do that. Likewise, if you think it's someone that you'd like to see again, how are you going to word that and how are you going to manage that? And these are good tips for anybody, not just people affected by cancer. Thinking about male sexuality and the concept of what it means to be masculine is sometimes quite important in the context of cancer and how cancer can adversely affect the aspects of someone's identity. Quite often, and this came from a publication which is quite old now, 2005, but it was really looking at how masculinity is constructed in the context of prostate cancer. And quite often men are expected to be very oriented towards their phallus, towards their penis, and that their penis has to be a certain size in order to be sexually successful or to be able to demonstrate masculine prowess, which is in fact really not a fact. It is, if you excuse the pun, a fallacy. And so the reality is that actually the size of a man's penis within reason is actually not what makes the sexual experience for them and their partner necessarily more or less enjoyable. It's much more about what someone does with their body and how they negotiate boundaries and change, rather than it being purely about physical size. But I do appreciate that for a man, and I'm not a man, I do appreciate that for a man or for someone with a penis, it can actually be very challenging when certain aspects of treatment can adversely affect the size of the penis. Many men will also think that sex has to begin with an erection and end with ejaculation, and many types of cancer treatment will adversely affect both of these physical functions. But actually, you can be sexual in many different and various ways, and it can be mutually enjoyable without ever being able to get an erection, or indeed, even after ejaculation has been lost, orgasm may feel different, but can certainly still be very enjoyable. The idea of a man being penetrating and powerful and lasting for a long time, all of these things again are often myths which men feel they've got to live up to, rather than actually knowing what works for you in your current relationship and also what works for you after a cancer experience. And I think this is indeed quite wrong, but again is quite commonly cited in terms of socially how we think about males or men and sex, is that it's a physical performance more than an emotional or an intimate act. And many men that I speak to say that actually going through an experience of cancer has actually brought them and their partners emotionally a lot closer, and they now experience sex in a much broader way compared to what things might have been like prior to their cancer diagnosis. Not everybody would say that, but certainly some men would say that, and their partners would say that too. The idea that a man always has to be ready for sex, is the person who initiates sex, who satisfies his partner, who always has 2 testicles and is always fertile. Again, many of these elements will be adversely affected by cancer treatment. But again, it's about thinking about, well, those might have been the pre-cancer roles that we as a couple inhabited, but actually what's to say that those roles couldn't be mixed up a little bit, couldn't actually be slightly different, so that the partner, whether that's a male partner or a female partner, is much more involved in initiating perhaps than would perhaps have readily been the case prior to their cancer, to the person's cancer diagnosis. So sometimes we need to look at how the relationship might need to evolve and change in order to accommodate some temporary or permanent changes brought about by our cancer experience. So there are many different challenges and sometimes struggles associated with that adaptation and change. There's often a decrease in sexual confidence, some negative attitudes about how sex is now. There is obviously the adjustment to things that we've lost, to things that we are grieving the loss of, and the doubt and the fear that comes along with that. Many people experience cancer treatment related fatigue for many months, in some cases sometimes for over a year post-treatment. Some people feel more connected to their partner after a cancer experience. Others feel that actually the relationship has become more distant and they need help to actually re-establish that connection. There might be differences in levels of desire between the partners, between the person who's gone through treatment and the person who is otherwise fit and well. There may be a change in who initiates sex after cancer. There might be a loss of spontaneity because there's a need to use assistive aids, particularly in terms of erectile function, which we'll talk a bit more about in a moment. There might be changes to our desire, to our arousability, and to our capacity and our sensation of orgasm. And all of those may result in a change in experience of what we find sexually pleasurable. But there are some strategies and self-management approaches that we can use and also that sexual counselling can help with. We can make sex more of a priority in our lives and our relationships and schedule specific times to be intimate and sexual together that gives us privacy and space and time to actually manage some of those changes and to find ways to work through them and actually work around them. We can think about engaging sexually together and in an erotic way without actually waiting for spontaneous desire or physical arousal to be present. Because quite often when we start being erotic and sensual together, that in itself is pleasurable and enjoyable and can actually enable us to actually feel connected with our partners and change the way we're communicating with each other. We can increase the direct expression of affection and promote intimacy by being more overt. So if, for example, being able to get aroused physically in terms of an erection isn't happening, particularly without assistance, then being able to say how we feel in our body, even though our penis might not be able to respond, can then be reassuring and helpful to the partner that actually we're still feeling those feelings through that sexual engagement with our partner. It's just our penis is not able to respond, perhaps because of nerve damage or arterial damage as a result of radiotherapy, radiotherapy, surgery, or perhaps hormone treatment. We can look at how we can identify low demand sensual activities to be intimate together. That might include things like using sex toys or different types of lubes to actually create sensations in our bodies, and being open to new ways of expressing ourselves sexually, which we may not have done since we started courting together or first dating with somebody, or indeed may not be things that we've ever tried, but might actually be useful for us to explore now together. And redefining what sexual pleasure is going to mean to each of us, which may be different from before or may be similar. But expecting sex to certainly be different, but not always worse than it was before cancer treatment. So thinking about erectile difficulties or erectile dysfunction more specifically, there are some top tips, I suppose, in terms of thinking that through. What we do know is that prior to treatment, the erectile function that was capable is the single most important thing that determines post-treatment recovery. So if we had difficult erections or difficulties maintaining an erection or getting an erection prior to treatment, then the treatment will make that situation worse, and it may be that we need a more intense level of erectile support post-treatment because we had some difficulties pre-treatment. So men that are younger, those who've had nerve-sparing surgery, those who have early use of post-operative erectile aids such as medication, tend to see better recovery rates than people who don't do anything and maybe don't do anything for a long period of months or maybe even a number of years. Sexual recovery, remember, can take up to 24 months to reach one's maximum potential, particularly after pelvic surgery. So it's not something that happens rapidly. It does take a number of months and can be, as I say, up to 2 and sometimes in excess of 2 years to reach the maximum potential for recovery. But generally speaking, most men will require some sort of assistive aid to actually help them with their erections post-treatment. There are very few men who are able to achieve an erection post-cancer treatment with no assistance whatsoever. There are a small number, but they would be generally a minority, or perhaps those who've got either a temporary hormone reduction level reason for their erection difficulties, or those where it's predominantly a psychological reason that, again, once we're able to help them with the psychological reason, then their erectile function physically can recover. Whereas those who've had nerve damage or arterial blood flow damage to the penis are likely to require assistive aids for erectile function. Androgen deprivation therapy, which is where we suppress men's levels of testosterone deliberately, particularly in the management of prostate cancer, reduces the effectiveness of oral drugs. So again, we need to be mindful therefore of what we tell men to expect in terms of their response to the likes of Viagra or Cialis or Levitra. And likewise, if we've got men who have got low hormone levels, not because they've got prostate cancer, but perhaps as a result of intensive chemotherapy, if it's oncologically safe to do so, then we need to think about getting their male hormone levels into the normal range in order to support their erectile function and their levels of desire and orgasm. Oral drugs, if we are going to use them, need to be tried on a minimum of 8 occasions at the maximum dose and with the optimal conditions, i.e. also including sexual stimulation. So if a gentleman uses oral drugs once and then finds that it doesn't work, they often lose confidence and don't try it again. But actually using it once is not usually sufficient. And this is to give people the opportunity to learn the timing of when to use the medication and how to use the medication and what works and what doesn't work, plus actually looking at what types of sexual stimulation are best to help with arousal, because that arousal is being supported by the tablet. It's not replacing the tablet. The tablet doesn't replace the arousal. All the tablet is doing is bringing extra blood into the arteries. What the arousal is doing is actually stimulating the mechanisms that actually create the erection. And psychosexual therapy can support both the patient and partners to adapt to the use of these different assistive aids for erectile changes and actually help other aspects of negotiating change in relation to sexual well-being. So can often be used helpfully in conjunction with medical treatments for sexual difficulties. Medication is not an aphrodisiac, so if you don't have any desire for sex, medication will not necessarily change that. And if you've got no desire and therefore you're not really responding psychologically to stimulation, then you may actually need sexual counselling to help you with that rather than medication alone. Medication doesn't work without sexual stimulation, so taking the tablet alone won't bring about an erection. You still have to engage in sexual stimulation, foreplay or erotic sensual behaviours together in order to create an erection with medication supporting that. Medication rarely works the first time, and sometimes we actually advocate starting with a higher dose to begin with and then titrating back rather than starting with a lower dose and titrating upwards. But again, that will be partly determined by what your GP or your treatment team feel is best for you based on their knowledge of the other aspects of your physical health, because there may be some reasons why we don't want to give you a higher dose to begin with in case it actually interacts with other medication or other health conditions that you might be experiencing. And there is no cure for erectile dysfunction, or at least rarely there is a cure. Quite often it's a way of managing it and learning how to actually adapt so that you get the best erectile function that you're capable of regaining, rather than imagining that you can completely resort right back to how things were prior to having any cancer treatment at all. The only exception to that, as I say, is where the reason for the erection difficulties is predominantly either due to a temporary physical change or indeed due to emotional disruption that can then be overcome. So here are the sorts of treatments that you might be offered or that you might already be trying to see how they work. We start off usually with tablets. They can be either sildenafil, which used to be called Viagra but is now available as a generic version of the drug, so it's a lot cheaper. Tadalafil, which used to be called Cialis, is also available as a generic medication on the NHS. And then there's other drugs like vardenafil and avanafil that are used less frequently. All of these tablets can be really useful, but all they do, as I say, is bring extra blood into the penis. If those tablets don't work, and we've tried them at maximum dose, and we've tried perhaps by switching from one tablet to another because they work in a similar way, but they all have slightly different characteristics, so it's worthwhile sometimes trying a different tablet. If the tablets aren't working, then usually there would be a move to actually then deliver the medication direct to the penis, and this is a different type of drug called alprostadil, and it can be delivered either by a pellet that gets put into the urethra, into the urine pipe in the penis, Vitaros, which is a cream which is applied to the tip of the penis and goes down again into the urethra, or by intracavernosal injection, where the man is taught how to inject using a small thin needle into the base of the penis to actually get the drug directly into the spaces where the blood comes in. And again, this drug, alprostadil, as an active drug, is solely bringing extra blood into the penis to create rigidity, which is necessary to create the erection. Sometimes men will also be taught about the use of a vacuum constriction device or a vacuum erection device, it's sometimes referred to as. And they can be really useful as a non-drug measure to actually enable the creation of an erection, and then to maintain the erection, a small ring which is elasticated that's round the base of the plastic cylinder there. It's mounted in advance of creating the erection by creating a vacuum which just draws blood into the penis to create rigidity, and then that stretchy ring is pulled down onto the base of the penis to actually trap the blood in there, a bit like putting an elastic band round the base of your finger, trapping the blood in there to actually keep the penis erect. That can be very useful. It's sometimes used also as a form of almost like physiotherapy to help stretch the the penile tissues and actually help create confidence to be able to create an erection. So sometimes you'll be given a vacuum device to use to stretch your penis and to bring blood into the penis, but not necessarily to use the constriction ring unless you want to. While others are using it purely as a way to actually create an erection in order to make love. And then if none of those things work, and the man and the couple are still wanting to look at something that will actually help create an erection, then in that situation what we would do is make a referral for someone to have a penile implant, which is a surgically implanted device. It's either, what's shown in the picture there is actually the inflatable penile implants, and where the little flat pack there that's like a little bottle in shape, that actually is put under the pubic skin, so it lies across the pubic area, and then the long cylinders are actually put up either side of the urethra inside the penis, and the little small button, if you like, is led into the scrotum so that the man can actually locate where this little valve is and can then pump the valve, and that moves fluid from the reservoir, which is under the pubic area, up into the actual balloons that are in the penis itself, thus creating an erection when an erection is needed. It's an operation that's done very regularly. There are relatively low levels of complications associated with it if the device that's chosen for the man is the right one, and the man himself is the right candidate for it. So it's definitely worthwhile considering if that's something that you would be interested in. There is another type of simpler implant which can be put in as well, which is what we call a malleable rod, which is just pushed down or pulled up according to when the person needs and wants an erection to make love. But it doesn't fully deflate, so there's always a very slight erection there. But again, it's a simpler mechanism and sometimes used in some cases. But these would be the sorts of things that could be discussed with a erectile dysfunction clinic, with your general practitioner, or indeed with your consultant. And if you need to be referred, you would be referred to either a urologist or an andrologist to have a consultation and a discussion about that possible surgery. But it's always discussed as a last issue, before we need to have tried these other things first, because once you've put an implant in, it's actually irreversible. So there's then no erectile tissue left behind, because you have to take the erectile tissue out in order to put the rods or the inflatable balloons in. So that's why we don't do that as a first choice. We try these other things first. But there are often many men who actually gain great benefit from having penile surgery to actually help with this, if that's something that they and their partner would want. And I've certainly worked with a number of men who found that a very successful option for them. In terms of reduced orgasm sensation or reduced orgasm intensity, this can sometimes happen. Particularly if you've lost the ability to ejaculate because you've had your prostate and seminal vesicles, which are near the prostate, removed. Sometimes you can get low orgasm sensation and difficulty reaching orgasm because your testosterone is a low level. Now, obviously, if you're being treated for prostate cancer, then it's less likely that you will be allowed to have testosterone supplementation. But if you are otherwise safe to receive testosterone and your levels of testosterone are low normal or below the normal range for your age, then again, testosterone supplementation can really help with orgasmic sensation and with arousability. So again, that can be discussed with your treatment team. Psychosexual therapy can sometimes be useful because it helps you relax and really focus on your body and on the ability to engage with the different types of stimulation and erotic sensations that you're feeling in your body, particularly if anxiety or low mood is adversely affecting your sexual well-being. So psychosexual therapy can certainly help with this, as well as explaining why you might be experiencing a change in your orgasm. We often use things like fantasy, erotic images and erotic literature, and encourage people to use pornographic images, if that's something that's acceptable to them, to actually help them become aroused and help them experience their orgasm in a more full way. If that's something that's acceptable to them, and if they're in a current relationship, it's acceptable to their partner to engage in that way. We often teach or modify masturbation techniques if the masturbation technique that the man is using is unhelpful or is part of the problem. We sometimes encourage the use of different types of lubricants, which can create sensations in the penis and therefore create a greater awareness of penile sensation. And sometimes we use vibrators and vibrator therapy, such as vibrating cock rings, again to help with additional arousal and stimulation of the penis to enhance orgasmic sensation. Some men, particularly after prostatectomy, experience the loss of urine at the point of orgasm, and this is referred to as climacturia. So when you reach your climax, some urine can be lost. This is a direct consequence of the neck of the bladder not being able to close as effectively as before because of the changes caused by the prostate surgery. Generally speaking, as you've done your pelvic floor exercises and your urinary control improves, usually the climacturia either lessens and or can actually be resolved totally. But for some men, there's still an element of climacturia that can sometimes persist. So again, a lot of it is teaching men about why it's happening and making them aware that although there's a small amount of urine that might be lost, it is sterile and it's non-harmful to the man and to his partner. And practical advice about preventing soiling at the time of being sexually intimate might be something that we also talk through. Some men find that if they go and pass urine immediately before making love, being able to empty their bladder fully beforehand again prevents them from then a small loss of urine at the time of intercourse. And there's also a technique that can be taught to men called bulbourethral massage, where there's sort of an upwards and forwards motion from the base of the scrotum upwards and towards the tip of the penis to try and stretch out and empty the long urethra, because sometimes urine pools in a little kind of U-bend and then comes out at the point of climax. So again, being able to fully empty the bladder and empty the penis or the urethra of urine prior to making love can sometimes be useful. Some men will use a condom to prevent urine from being expelled onto the bedclothes or at the time of intercourse. And some men will use a constriction ring or constriction loop, as in the diagrams there, because when you're wearing a constriction loop, as well as helping maintain the strength of your erection, it also prevents urine from coming out the tip. So that can be quite useful as well. But again, these are often things worthwhile talking through with your urologist or andrologist or with your psychosexual therapist. There are some podcasts available that can give you further information about sexual well-being after cancer. I mentioned the Shine Cancer Support podcasts. They can be very useful. They're designed for both genders and different types of relationships. And there's also a recent podcast that was recorded by Liz O'Riordan. And although the focus between Liz O'Riordan, who's a person who's been treated for cancer herself, she was treated for breast cancer, and Samantha Evans, who's an ex-nurse but actually runs a sexual products website, they do talk about both male and female toys and tricks and tips. So again, listening to that podcast might well give you some ideas about sexual well-being and how to take that forward as a couple. Sex with Cancer is a new organisation that was launched last year. It's run jointly by two people who've been treated for cancer. One is a young woman treated for breast cancer. The other one is a gentleman who's treated for testicular cancer. Both of them work in conjunction with a company called Shush, which is an online sexual products company. And they have got a range of different things on their website that again help with sexual enjoyment and sexual well-being after cancer. They have an online shop which has got products that might be suitable to help you with different sexual challenges. They also, because they come from an art background, they've got poetry, they've got art installations, and they've got different ways, I suppose, of thinking about and expressing sexual well-being that go beyond just talking, but actually go about the ways in which we express our sexual changes as human beings through art and media. So again, you might find that quite useful. And this is about people taking responsibility for their health and well-being from a sexual perspective. So the emphasis is very much on well-being and enjoyment rather than on deficit and difficulty. But they do also have a panel of experts who've helped answer a number of questions that were posed by people who've been affected by cancer in relation to their sexual well-being. And so again, you can pose questions and you can get specific help by people who are trained in sexual medicine and psychosexual therapy that can actually assist you through this website. For those of you who may be experiencing erection difficulties for predominantly emotional or psychological reasons such as anxiety or low mood, This is a very useful app which has got a lot of principles in it that we use in sex therapy, and it's designed for men who haven't been treated for cancer, but there are many strategies on it that can be very, very helpful for those of you overcoming sexual challenges from an anxiety and emotional point of view. So I can certainly highly recommend it, and you can usually access the app for a week free to see what's in it. And anybody can sign up to do that, including clinicians. And then obviously if you feel that the stuff that's in there isn't helpful to you, then you can just not bother, or you can actually then subscribe to it, and that gives you prolonged access to it. And then there are other sources of online help as well. So the College of Sexual and Relationship Therapists, or COSRAT, they have a section in their website called Find a Therapist. So if you weren't sure who was your local psychosexual therapy services, where to find them, you can certainly find therapists there. And although most of these therapists will be private therapists rather than working in the NHS, some of them are likely to know where the local NHS services are based, and some of them will work in NHS as well as in private sector services, but they're all represented on this COSRAT website. For those of you in England, or in Wales, Relate, which is a charity, they are about relationships, but many Relate therapists are also trained psychosexual therapists. And so if you're experiencing sexual difficulties as a couple, or indeed any general relationship difficulties arising from your illness and treatment, then again, accessing your local Relate centre, and there are centres in most towns and cities in the UK, is another low cost, and sometimes for some people on a low income, it's also a free access ability to get psychosexual therapy if that's what you're looking for. Tavistock Relationships, which is based in London, they do online psychosexual therapy for people, again, who are able to self-pay. The Institute of Psychosexual Medicine will give you a list of local sexual medicine consultants and experts that are living and working in your area. Again, you're then able to find out whether they're working in an NHS service, and that is then possibly a way of you being able to ask your GP to get referred to see a sexual medicine expert to help you with your sexual challenges. And then there is a new company called Percy Health, which is a specific oncology online supportive cancer care service, which is delivered by telemedicine, so it's all online. And they do also have psychosexual therapy as one of their services, but again, it's on a self-pay basis, but they do offer 20, 40 and 60-minute sessions. So again, if perhaps it's prohibitively expensive to go for something for a very long time, if you've got a quick query that you think could be resolved in a 20-minute session, just to talk and clarify something, or get some ideas about where you could find further help, then again you can access that sort of service through Percy Health, as well as a range of other supportive care services like physiotherapy and other types of therapy, if that's a direction that you want to go in, to get help that you might not find available in your NHS service, or you may not have access to locally. Other sources of support through charitable sector, as well as Penny Braun, of course, is Shine, Prostate Cancer UK. They have specialist nurses helpline, and again are very knowledgeable about the management of sexual difficulties, particularly after prostate cancer treatment. Orchid, which is a male cancers help group, so addressing a number of cancers that are especially affecting men. If someone is in a same-sex partnership, then Out With Prostate Cancer is very helpful for those who identify as being gay, bisexual men and indeed trans women. And the LGBT Walnut Support Group, there are ones based in London, Dorset and Eastbourne, again, particularly for gay, bisexual or transsexual men. And then an LGBTQI Cancer Support UK charity called Live Through This, again a very helpful source of support for individuals who self-identify as gay, bisexual or transsexual.